Let's get started, everyone. So, welcome. A couple of announcements. First, faculty members remember to sign in and complete your forms for CME so that you get CME credit. Special thank you to Kyle Ward for the collection for the holiday gift. And thank you to all of you for generously giving. And I think Ashwini was also helping collect, doing some of the legwork as well. So thank you very much.
Caesar as well.
And Caesar as well. So thank you. It was a very wonderful group effort, and I'm sure we very much appreciate it by the children and adolescents who often have a rough time. Also, thank you to the singers. Do we have any of the singers here? The carolers who were caroling yesterday.
They're moseying.
They're moseying in. Yeah, we may require them to do an encore right at the end of Grand Rounds here. So today we have Dr. Gilman, whom I think most of you know. She graduated, she did her psychiatry residency at Temple and did a psycho-oncology and CNL fellowship at Weill Cornell Memorial Sloan Kettering. And she'll be talking to us today about grief in physicians as it relates to losing patients. So she did a really terrific job helping us to learn about Erickson's stages of life. And so I think we're in for a treat today. So please join me in welcoming Dr. Megan Gilman.
All right, so yeah, the title of my talk is I'm Okay, You're Okay, a look at physician grief. I'm really excited. I love this talk. It's a topic that I became really interested in during my fellowship at Sloan Kettering. And it's a topic that's really not addressed, and it does refer specifically to patient loss after medical death, so separate of something like suicide. Although at the end we can talk about some of the overlap in responses to psychiatrists who lose a patient to suicide and doctors who lose a patient to a medical death. So the objectives for my talk, we're going to go over some of the definitions of grief in the literature, consider some of the differences in gender that show up in the research regarding expression of grief among patients, consider the role of the attending as someone who can model for trainees sort of how to deal with these grief reactions, and understand the risk factors for physician grief. So I put risk factors in quotation. It was kind of interesting. I hadn't put it in quotation marks at first, and then I realized I was completely pathologizing a normal reaction, which is sort of the point of the talk. So it is risk factors because this is not a pathologic reaction. And discussing the institutional grief interventions, and that's something I'm super interested in, is kind of what can we do as psychiatry to help support our colleagues who are really facing these reactions on a regular basis. So I don't have any financial disclosures on this topic, but I do want to start the talk with a different kind of disclosure. So in my 12 months of psycho-oncology fellowship at Memorial Sloan Kettering, I lost 26 patients. Some of them were patients that I had only seen a couple times as a consult when they were already in the ICU, but some of these were patients that were coming to my outpatient office weekly for 7 or 8 months. And there was one particularly difficult loss. I'm going to talk to you a little bit about this patient and about how I experienced the loss of this patient when he did die. His name was Christopher. He was 21 years old, and he had a diagnosis of HLH, which is hemophagocytic lymphohistiocytosis. It's a pretty rare disorder that more commonly occurs as a familial disease in infants, but it can occur in older people when it's related to a malignancy. It has about a 50-50 death rate, cure rate, and if it is associated with malignancy later in life, the time from diagnosis to death is usually around 6 months. So I tell you all of this because this is not a presentation about this diagnosis. It's about Christopher, but I think that's significant to kind of how I came to know him and get involved in his care. So Christopher was diagnosed just before his 20th birthday with this disease. And at the time that I met him, he had spent almost an entire year on the inpatient unit, the pediatric unit at Sloan Kettering. And the reason I was assigned his case right when I started in July was because he was not speaking to any of the treatment team members at that point. He was very angry. He was angry at the people that he felt had been keeping him in the hospital. And so they thought that if they sent me in and I was a new face, maybe we could get along a little better. When I went in, he had a big poster above his bed that said, "Happy 21st birthday," signed by family and friends. So he had just celebrated his 21st birthday in the hospital. He asked me if I was with Psychiatry. I said I was, and then he said, "Can you get me off this Klonopin because I have a BMW at home and I want to drive it, and my mom says I can't drive if I'm taking Klonopin." So I told him we could look into that. I asked him a couple more questions. He was pretty dismissive in a very kind of adolescent way. He kind of joked around a little bit. I asked if I could come back and see him. He was actually being prepared for discharge at this point. They were just waiting to set up some of the home care PT and things like that. And the plan was for me to see him when he came back for his monthly follow-ups. Unfortunately, 3 days after he got home, he had a major crisis, came back in completely delirious. I saw him at that time. He was very disoriented, he was hallucinating, and he was readmitted. And he never left the hospital after that. So that was in July. I saw him, I would say on average 6 days a week from July until he died in the adult ICU in November. And we had two kind of different interactions with Christopher. There were days where he was very clear and I would walk in and he would say, "Can you just leave me alone? Nothing wrong. I'm not anxious. I'm not depressed. Just leave me alone." And then there were times where he was delirious, and it was sort of endearing because he would recognize me, but not the context in which he knew me. And so he would often ask if I wanted to go out to dinner at KFC. And so it became clear that he didn't like me in some way. He was just angry at everyone who was sort of forcing this disease on him, forcing this hospitalization on him. He had a really difficult course. He was in and out of the ICU. Part of this disease is sort of multi-organ failure sets in. And so he would be in renal failure and go to the PICU, and then they'd stabilize that and he'd come back to the acute floor, and then he'd be in respiratory failure and he'd go to the PICU, and he was in and out of delirium and being clear. And eventually he started to talk to me a little bit, but it was always very brief interactions. I would sort of make myself just kind of present in the room, and if he wanted to share something, he would. And one of my more memorable encounters with him, he was getting pretty sick. He had lost a lot of weight. He was having difficulty breathing. He was requiring oxygen for the first time. And I went in and he said, "Can you just leave? I don't want to talk right now." And I said, "Okay, I'm here if you want to talk." And I started to leave, and he said, "Thanks for caring, though." And I was like, okay, something's happening here. He's acknowledging that I do care and that I am a resource for him. I was on rounds on the adult service when I got a page one day that Christopher had developed pericardial effusion with cardiac tamponade and would have to go for emergency surgery. And basically, he had about a 90% chance of dying after the surgery and a 100% chance of dying if he didn't have the surgery, so his mother agreed to the surgery. And I ran up to the pediatric floor, and he was just sitting on the edge of the bed with a million nurses and doctors around him. He was hunched over, and he was just having so much difficulty breathing, and we just kind of made eye contact at the door, and I never saw him wake after that. He never woke up after the surgery. The last 10 days of his life, he was in the ICU. I spent every evening sitting by his bedside with his mother. I got to know her very well. I was there when his siblings came in to make handprints with the child life workers and make souvenirs, necklaces they could wear with his fingerprint on it. And they had actually asked me to be there that evening when the siblings came in. It was a really difficult experience, but very worthwhile. And then sorry, I still get choked up. When Christopher died, for some reason, despite there having been like 30 people in the room at the moment of his death, it was just me and his mom, each holding one of his hands. And then the ICU resident came in and declared him. And the family arrived, and I spent the rest of the day just helping to support the family and collect his belongings. And it was just a really, it was sad. And I mean, I still get upset about it. I think I didn't know why I was so sad about it. And that's sort of what led me to really explore this topic and how do we deal with that. I had lost all these other patients, and in the moment that I heard they had passed, I would feel sadness. But then I sort of moved on, and I went to see my next patient. And there was something about Christopher that I wasn't moving on. It was very sad. And when I would walk home, if a BMW drove past me on 2nd Avenue, I would start crying. And I felt the need to talk about him all the time. I just wanted anyone who would listen, I just wanted to talk about my experience working with him. And it was just to understand like why this one case had just really hit me as hard as it did. It was what was this feeling, and sort of do I have a right to feel sad and miss this person who was my patient? So I started to prepare this talk for our January symposium, kind of wondering like what do doctors do when there is someone that really affects you, that really you miss that person. You know, I found that I was missing Christopher when I wasn't seeing him anymore. It wasn't just, it wasn't just an interesting case. It wasn't just, another patient on my list. I was missing him as a person. So that's how I came around to exploring this topic. So I think this is a really magical quote about medicine. Medicine is repeated attempts to cure while knowing that any cure is temporary. And it's true, right? I mean, in medicine, as the overarching definition of medicine, our patients are going to die. And we're human beings, and we have reactions to people's death. So the different kinds of reactions that physicians can have to a patient death range from either accepting that death as something expected. It was, calculated down to the hours and days. You had been sort of anticipating it. An absence of reaction. There are patients that we meet only briefly or we don't form some kind of relationship with, and they die, and it is just another case. Sometimes physicians feel relief when a patient dies, particularly if it was a particularly difficult family situation that was always stressful to walk into the room to, where the patient had been suffering for a long time, and every day having to go in and see that person suffering. And there's some guilt that comes with that reaction, but it's more just like, I don't have to see this patient anymore. Is a common reaction for certain types of patients. And then there's grief. So grief is one type of reaction to patient loss. So what is grief? So grief are emotional and mental responses to a loss, a physical absence of someone or something. And this one I think this definition is particularly poignant for medicine, the end of a shared experience. Because that's really what it is when we interact with a patient on a close level. It's a shared experience. They have their part, we have our part, and we're sort of doing this together. And so there is an end to that when that patient expires. Grief is not physician stress, and grief is not burnout. But if you don't address the grief and you don't resolve the grief, it has been shown to lead to physician burnout. So it is an important thing to address in our colleagues and in ourselves if we experience it. There are different kinds of grief that are talked about in the literature. Acute grief is just what it sounds like. It's that immediate feeling of sadness or anger or whichever Kubler-Ross spin the wheel reaction you have in the immediate moment after a loss. There's anticipatory grief, and anticipatory grief is really interesting because it occurs for the patient as well as the family as well as the physician. It's when everyone knows that the patient is nearing death, and there's this process of grieving that starts prior to the death. Lifelong grief. That usually refers to a parent who has lost a child, They're never really expected to completely resolve that grief, but rather learn how to function while carrying that grief with them. Recurrent grief, and this comes up a lot in the literature in pediatric oncology, because each death is sort of poignant and meaningful and difficult, and it becomes part of the flow of their daily routine that they're carrying a new grief after a new grief after a new grief. Disenfranchised grief. I think physician grief actually falls under this category. Disenfranchised grief pertains to those types of grieving that we do that aren't sort of accepted, where, you know, when your cat dies, it's not like all the neighbors are going to bring over casseroles, or a divorce that people are grieving. It's not necessarily accepted in the same way that a normal loss of a spouse to an illness would be addressed by your peers in your community. And I do think physician grief falls under this category. We kind of don't know if we're allowed to have it, if we're allowed to show it, and kind of what we do with it when it's there. There's not a sort of designated place for us to feel these things. And unresolved grief. And again, that is what I really want to talk about today, is when that grief is unresolved, it does affect us in negative ways. And like I mentioned, it has been shown to be a contributor to burnout. So some of the symptoms of physician grief that are reported in the literature, so these are from a number of different studies that are basically survey-based. So physicians are reporting what they experienced after difficult patient losses. They have described feelings of powerlessness, self-doubt, and that obviously can have a really significant effect on our work if we're sort of doubting our own abilities and doubting our own knowledge, and guilt. Feeling guilt about, you know, should I have done this differently? Should I have done more? What is my role in this death occurring at this time? A sense of failure, right? This is your patient, this is your case, and that patient dies. Is that your fault, right? And people can experience a real sense of failure around losses that are particularly difficult. Feelings of sadness, right? Someone dies, it's totally human and normal to feel sad if you felt like you had some connection with that person. And one of the most common reported symptoms by physicians is loss of sleep. People actually experience insomnia or interrupted sleep in the aftermath of a particularly difficult patient loss. Some of the impacts of physician grief. So as I mentioned, if it's not resolved, it can increase stress and lead to burnout. Compartmentalization. So this is where the physician goes to work, they don't think about it, they do what they need to do, but it's when they get home that they're just overwhelmed by these feelings that they've just been putting aside in order to do their work. Emotional exhaustion. And that really comes into play with the pediatric oncology recurrent grief that I was talking about. At some point, it's exhausting to continue feeling these things. It's exhausting to continue carrying all of this grieving with you. Distraction, right, which can be really detrimental. If you're not dealing with these feelings and they're just sort of hanging in the background, it's easy to kind of make a mistake, because really what you're thinking about is this thing that you're trying very hard not to think about. And distancing or withdrawing oneself from future patients. That's a big problem, that when a physician experiences a particularly difficult patient loss and is experiencing feelings of sadness and grief, there is a reaction where the next patient, they're not going to allow themselves to get that close to that patient. And so that obviously decreases the level of care that they would prefer to be giving, but it's a protective response to not wanting to feel that again. Some positive impacts of physician grief are also reported by physicians. So it provides a normalization of death, that we kind of feel lucky that death isn't this great mystery at some point when you really are experiencing it as part of your daily career. A motivation to improve patient care. Is there something that could have gone better in a system-wide sense? Is there something that we can change, and kind of motivating this kind of improvement-minded response to a patient loss? And having a new perspective on life. And a lot of physicians in the literature have reported that after a particularly difficult loss, they feel like they appreciate what they have more. They appreciate their family more. They appreciate all being alive and having their health and all of these things. So this is a really cool study. Doctors' emotional reactions to recent death of a patient. It was published in BMJ in 2003. And what they did was they looked at these index patient deaths. So it was a patient that had been in the hospital for more than 24 hours, that the death occurred on either a medicine or intensive care unit, and how staff was involved in the care of that patient. So when they say doctors in the title here, they're actually referring to what the study broke down into 3 groups: medical students and interns, residents, and primary attending physicians. So they contacted they identified 251 doctors who had cared for 81 patients who had died during the course of a hospitalization. And 246 of those doctors remembered caring for that patient. They sent surveys to those doctors, and they had an 80% response rate. Yeah, that's huge. It is a huge survey response rate, and we're talking about us. We all know how busy we are, and the fact that 80% of 250 physicians and medical students and trainees took the time to respond tells us that our colleagues want to be talking about this, right? We want to be able to talk about this. So as soon as they were offered an outlet, they jumped at that opportunity. So I think that's a really significant thing, that there is a desire to discuss these feelings, and is there a way that we can provide an outlet for that? So these are some of the results from the study. In terms of the index cases, for 82% of the physicians, their first encounter with the patient was during this final admission. So they hadn't met the patient before, the patient got admitted, and the patient died during the course of that hospitalization. 36% treated the patient for 3 days or less, 36% for 4 to 7 days, and 28% of the doctors treated the patient for more than a week. The longer the duration of care, the closer the doctors reported feeling to that patient, which is sort of predictable. But the longer the duration of care was, the doctors were more likely to report a feeling of satisfaction around having been involved in the care of that patient during their end of life. For doctors who reported not feeling satisfied with that patient encounter, there were 3 main things that they felt interfered with their ability to feel satisfied with being the caregiver at that patient's end of life. 17% reported that conflict with family members and other healthcare team members regarding goals of care really left them feeling unsatisfied and just sort of distressed over the interaction. 13% said that patient suffering interfered with their ability to feel a sense of satisfaction, and 4% attributed to poor symptom management, which is sort of along the lines of patient suffering, that they just felt like not enough had been done, and people who felt that really didn't express that feeling of satisfaction at being in this role. So female doctors reported more grief symptoms than male doctors, and interns reported more grief symptoms than attendings. But note the italics, because I feel pretty strongly that this is more driven by kind of what's socially acceptable and acceptable in our field, that it's easier for women to express emotional reactions. There's more ways for them to do that. It's more comfortable. And similarly, I think that it's within medicine, it's easier for an intern or medical student to express a feeling of sadness or loss than what would be accepted from an attending physician, really expressing that in our culture of medicine. Female doctors reported using more coping behaviors than male doctors. And I think this is really interesting. Residents reported using more coping behaviors than either interns or attendings. And interns here refers to medical students and interns. And I think that's really important because it says that there is something to be taught, right? These are people who are further along in their training. So have they gained something that allowed them to have more access to these coping behaviors at a further step in their training? Is there an opening for us to really address how do we deal with these feelings? Female doctors reported needing more emotional support than male doctors. And interns reported needing more emotional support than attendings. And again, I would say that this is being driven by sort of cultural norms, not actually a reflection on what people are actually feeling, more what they felt they could admit to. Some of the coping mechanisms that physicians describe using when they are feeling grief after a patient loss include intellectualization, like, I don't know, putting together grand rounds on physician grief, blame, right? Blaming themselves, blaming their colleagues, blaming somebody, right? It's like something outside of the actual patient just coming to that time in their life course. Religiosity or fatalism. Some physicians report feeling like, well, it was out of my hands, you know, that's how it went. It wasn't up to anybody here, is a way for them to cope with that loss. Gallows humor, I think we use that a lot in psychiatry in particular. We don't have as many patient deaths, but we certainly see some really difficult cases, and I think that being able to joke about things is a way to cope with like what's really underlying them. Paternalism, kind of stepping into the next case, like I'm here, I'm going to take care of everything, and you know, kind of taking on this more traditional role of telling the patient what to do and feeling comforted by knowing you can step into that role. Heroism, again, like the next case, kind of going the extra mile, doing everything you can possibly do for the next patient before they die. And by doing that, I can say that I've done everything possible. And then teamwork and sharing of experiences. And I would say that in my experience in my fellowship, the fellows really supported each other. We actually, when someone would lose a patient, they would send a text to the other fellows just saying, Mr. So-and-so expired. And we would all text back and say, you know, you did a great job with them. Like, you know, I'm sorry to hear that. You did such good work with him. And it sort of became like a routine for us. It was a really, really necessary coping mechanism for us to kind of get through our days and move on to case after case after case. Crying. I love this quote. Please, fellow physicians, don't cry in empty rooms or stairwells or in locker rooms. Cry in public and let the patients and staff heal you and see you are human. So crying on the job is most frequently related to the death of a patient. 73% of medical students in one study reported crying during clinical rotation due to the suffering and death of a patient. In another study, 76% of nurses and 57% of doctors cried in the hospital because they felt they had identified with and bonded with dying patients and their families. So deaths happen, right? They're going to happen. In fact, oncologists report 1 to 10 patient deaths per month with a mean of 4, and some experiencing up to 3 deaths per week. Pediatric oncologists experience an average of 1.5 patient deaths per month. About half of emergency medicine physicians witness a death per month and 17% a death per week, and I'm sure that somewhere like our ER, it's much higher. In a level 1 trauma center, there's a lot of patient deaths occurring in a short amount of time. And 57% of medical students during an internal medicine rotation said they consider a patient's death to be emotionally powerful. What makes us grieve? So the deaths are happening, but what makes us really grieve those deaths? Because as I mentioned, there are different reactions we can have, and grief is just one of those reactions. So Granick does a lot of grief research and particularly looks at grief in the medical field. She's done studies of nurses and medical students and attendings, emergency room physicians, oncologists, ICU doctors. This was a really beautiful paper that breaks down into relational, contextual, and cultural factors. These are the risk factors I was referring to. So these are the things about a case that are more likely to affect us in a way that it just doesn't go away afterwards. The relational factors include close families known to the physician. So when you know the family and the patient dies, you're really there witnessing the impact of the loss on people that you have come to know. And that was certainly true for me with Christopher. I had gotten to know his mother so well, especially that last week in the ICU, got to meet his siblings. And so when he did die, it was this I felt for them. There was a lot of, empathy for these people that I had felt very close to. Transference and identification. Physicians definitely experience increased empathy with patients that remind them of themselves, that are, particularly doctors treating doctors. Is a very difficult patient loss when it's a young physician that the young physician is losing. Someone who reminds a doctor of their wife or their brother, and that tends to affect us more when we feel that identification. A young age of a patient, and this was certainly true with Christopher. There's a sense of injustice when a young patient dies, and that really was my immediate reaction, was this is so unfair, and that's a very difficult thing to resolve. I think it takes time and it takes effort, and you really have to work to resolve that feeling, because it can be very frustrating if not. So that sense of injustice that comes with the loss of someone really young. An unexpected death. So the more hopeful the physician is that the patient is going to do well, the harder it is to sort of accept and move on when they sort of suddenly expire. Long-term doctor-patient relationship, as I mentioned in that one study, but it's sort of shown throughout the literature that the longer a physician cares for a patient, the more difficult that patient loss is, which makes perfect sense. And I do think was a factor in why Christopher's loss was so significant for me, is, like I said, I've been seeing him for 5 months, 6 to 7 days a week, and spending a lot of time as part of his life, basically, in the hospital. The contextual factors that Brandon talks about, unprepared families and patients. So when a physician delays letting the family and the patient know that it's really time to stop the active treatment and move on to something more palliative, that there is nothing else active to do, and then that patient dies when the family and the patient aren't sort of prepared for that, there can be a lot of guilt for the physician in not having brought that to the attention of the patient and the family in time for them to sort of deal with it. And also, I think it's particularly hard because some of that is your own denial, right? I mean, you're saying everything's fine, you're looking on the lab reports and everything's not fine, but maybe we can do this, maybe we can try this. And so it's a harder loss. Unrealistic expectations and excessive treatments. So the more the patient suffers, the more stress the physician experiences, and the more difficult the loss when the patient dies. And I think this was another factor in Christopher's death, was his mother was particularly distressed that she had agreed to this surgery, because otherwise she could have taken him home on hospice and he would have been home for the first time in a year and a half when he died. And I think for the physicians pushing this surgery that everyone knew was 99% likely to end in the way that it did, there is some difficult sort of rationalizing, like, did we do, was that the right thing to do? Did we make this death more difficult for everyone? Physician blame and negligence. So, of course, if there's any implication of the physician in the cause of death, the stress level goes up. And there's a certain kind of grieving that I think happens with that, and it's sort of more personalized. It's grieving for the loss of the physician's confidence in their own care. And then chaotic high-need families have been reported to really increase the difficulty of dealing with the patient loss. So when the family itself is very needy or unstable, the physician has a more difficult time around the actual patient death, because you're dealing with people who are sort of exacerbating your own emotions and challenging you to continue being involved in this situation. Cultural factors. So stigma around death and dying, right? So even though in medicine people are around people who are dying all the time, there's still this push to kind of avoid it. And whether that's always focusing on the cure, whether that's not going to the patient's room once you know that there's not a lot else you can do. I've talked to a lot of medical doctors who talk about that it's a trickle-down effect. It's sort of like you're on rounds, and the one day the patient's just lying there at end of life, and the first day it's the attending who's like, well, I don't need to see them today, you know, but just tell me about them. And then a couple days later, it's the senior resident who says to the junior, well, that's okay, just tell me about it. I don't need to see him today. You know, till it's just the third year medical student going in to see the dying patient. And I think that does come from a sense of avoidance and not wanting to confront that too closely. Affect is weakness. So the perception in medicine that crying or showing that you're sad or expressing your emotions is weak or unprofessional. I obviously don't think that's true. I mean, I think it's very important for us to feel what we're feeling around the people who can support us and understand what we're feeling. And so to be able to do that in the setting where other people know what we're talking about is a really important thing for getting through these difficult death losses. The culture of cure, focusing on control and cure, rather than the potential for that patient to die. And that was something that was very true at Sloan Kettering. People came there for miracles. They came there because every other oncologist had said, there's nothing we can do. And they came there to get on some crazy new trial. They came there because their, friend's dad had his stage 4 pancreatic cancer cured and is like in Costa Rica right now, and they came there to get better. So it was great when those things happened, and they did happen. But the patients who that didn't happen for, it was very difficult for the teams to deal with sometimes. And like I mentioned, the cultural factors around gender. Female doctors speak more openly about grief at home and at work. Male doctors report that if they do talk about their grief over a patient loss at all, it would more likely be with a female colleague. So I think there is some element of welcoming everybody into a place where these are acceptable conversations to be having. And the hidden curriculum. This is something I think is really important. If an attending doesn't react to a difficult patient loss, then the resident learns not to react to that loss, and the medical student learns not to react to that loss, and everybody's carrying around unresolved feelings of grief through their entire careers. Whereas if it can start at the top, or if it can start in like a form of didactics, or it's okay, you're going to feel these things. Like, here's how I deal with it. I think that's a really important modeling that should be taking place more, especially in oncology fellowships, for example, or where they're losing tons of patients, and it's really the beginning of the physician's career, and they're sort of seeing how many patients they're losing. They're looking for a way to deal with that. And so if that's not being modeled for them, it just sort of trickles down and continues to be contributing to burnout and things like that. And then the various settings and specialties. So each specialty sort of has its own challenges to dealing with grief. In the emergency room, for example, there's a lot of literature on PTSD in emergency department residents. And a lot of that is thought to be contributed to by they never resolve feelings of grief. They have, some terrible traumatic death of a young patient, and the family's there screaming, and they have to go talk to them. But then there's another screaming traumatic case, and then there's another, and there just isn't the time, right? And if you're not building that time in for people, then they're just carrying this with them. So how can we kind of address this in like an institutional way? Of course, encouraging personal reflection and taking care of one's individual needs is always a good idea. But some other more sort of formalized approaches are psychosocial debriefings. So I actually was involved in organizing the very first psychosocial debriefing at Memorial Sloan Kettering on the pediatric floor. It was the first time they'd ever done one. It was a 16-year-old girl who had been very well known. She'd been treated there since she was 13. And she was very well known to everyone in the hospital. She was very sweet. She was terminal, but she was actually still in active treatment and doing well. So the conversation hadn't occurred yet with the family. It wasn't the direction of the team that she was going to die anytime soon. And she was taken into the ICU procedure room for a bronchoscopy, and she coded and she died. And the family arrived and started throwing themselves on the floor and screaming, "You killed my baby, you killed my baby," while the resident who was doing the procedure was just standing there with this family screaming, "You killed my baby." They paged anyone who had anything to do with psychiatry or psychology or taught school, or, I mean, they would like literally come help us, anyone who knows about feelings. And so I ran up there and I remember seeing the resident standing there, and I mentioned to my attending, like, she didn't look fine. She didn't look good. So my attending spoke with her afterwards, and in fact, she was not okay. She was really not dealing with the whole situation well at all. So we organized a psychosocial debrief in addition to the regular code debriefing that the team would have. And it was really lovely, and it was a really beautiful opportunity for her to hear that her attending supported her and did not think that she killed this patient. It was an opportunity for people who were really feeling the loss of this particular patient to share some of their sort of memories about her and some of their feelings about her having died in such an unexpected way. And it was really beneficial. There's also physician support groups, death talks or death rounds. And we had this at Sloan as well for the fellows. Once a month, we all met, guided by one of our attendings, and we basically just talked about the patients we had lost. We could either just say their names, or if we wanted to say something about the specific patient, we could do that. But it was a really nice environment to be able to talk about, I miss this person, this human being, not just, this is what they had and this is what they were on. Institutional bereavement groups, so things like Schwartz rounds, which I didn't realize Einstein has, which is cool. So do you guys know what Schwartz rounds are? It was this basically a medical legal attorney who was diagnosed with stage 4 lung cancer. He was a non-smoker, he was very healthy, he was married, he had 2 small kids, and they started a foundation. And Schwartz rounds are designed to encourage compassion in medicine. So at each round, I think they're usually monthly, a certain case is presented that has a lot of psychosocial elements to it, or a lot of emotional weight to it. But again, these are things that are structured and organized and not sort of occurring in the moment, right? These are things that you wait a month or so to talk about, but there still are organized outlets for that. More and earlier training around coping with difficult patient death. And I think this is something I'm very much a proponent of, that in our didactics in medical school, it's not just about breaking the bad news to the SP, right? It's like, how am I going to deal when I feel sad? How am I going to deal with that feeling when this case just like makes me run to the bathroom and cry? Is that something that's okay? Is that what can I do with these feelings? I'm letting people know that these experiences are going to happen. And then recognizing the impact of either recurrent or unresolved or disenfranchised grief in burnout. And burnout is such a big problem, and if this is one aspect of it that's really not being addressed for most of our colleagues, is there a way that we can get to them through that, right? Everybody wants to talk about burnout. Well, here's something that might be contributing. How can we support you around this feeling of grief and loss? I just wanted to end with, these are questions from a semi-structured interview sent out in one of Granik's studies to physicians. And I just sort of thought everyone could just kind of take a look at them to kind of consider them. How did you come to choose your specialty? What are some of the best parts of being in the specialty? And what are some of the hardest parts? And now think about one patient who died that's particularly difficult for you. Can you describe the patient, and how did you feel when they died? Would you say that you felt grief? And if so, what was that grief like for you? And so for me, this was a really significant thing. So here I am intellectualizing my grief reaction and putting together this talk and looking in the literature. And I came across something that really helped me organize what I had been feeling, identified it as something, grief, and allowed me to see it in the bigger construct of what I had chosen to do with my life. That people die, sick people die faster, usually, and more predictably, and we're physicians, and as physicians, our patients are going to die. And so seeing it in that context, but allowing that to be part of that story was something that I found very helpful in allowing me to feel what I was feeling and really resolve that. And successfully move on to treating people with the same enthusiasm and care, and allowing myself to feel close to people again. So that's what I've got on physician grief. So I'm super interested to hear if you guys, your thoughts on this, any experiences that you've had with this being addressed or specifically not addressed, or specific questions that you have about the literature or anything. No?
Were there specific guidelines or anything that you did during fellowship to kind of help you with, I guess, grief within the family?
Yeah, so I think that was probably the most, I would say the thing I learned in fellowship that I had not been exposed to previously was really that relationship with the family in really high emotion situations, and learning how to discuss with them, learning how to make an opening for them to feel what they needed to feel, but feel supported. We did learn sort of specific techniques around that. Things that were a big thing for us was always finding a way to give some kind of physical touch. So when a family member was particularly distressed and particularly emotional, offering physical touch, so they're still expressing their emotion. You're not jumping in to say, "Hi, I'm a psychiatrist, how can I help?" You're letting them express those feelings, but they know that you're there. Calling the chaplain was a big thing, especially if we knew something was kind of about to happen. We'd have chaplaincy present if that was something that was helpful for that family. And then just sort of being available. And I think with families, the most important thing and the most difficult thing was that our presence was really ultimately appreciated. And so we sort of sit with them while they experience these really intense feelings of grief and loss, which was, it's a difficult thing to sit through, but the good thing about being present through it is that when they do come around and they do want to ask questions or they do want to share something, you're there. And I think that was sort of the arc of those encounters, tended to be a big expression of grief, sort of physical contact, physically being in the room, and then they would sort of turn and see that you were still there and start asking questions or start talking about their loved one or whatever it was. And just knowing that you were present was really important. So it was something that was new for me, the encounters with the family, and it was something that was particularly difficult, but it did actually kind of have a pretty regular flow that we kind of learned our steps, I would say. Okay. I will just mention, because we have a couple minutes, that when you look at the literature on how psychiatrists respond after suicide, it's not all that different. I think the biggest difference is for a psychiatrist who loses a patient to suicide, feelings of guilt and powerlessness are sort of harder to resolve and occur sort of more regularly as part of the grief process. Whereas for medical doctors, there are plenty of cases where they don't experience that. When they do, it's particularly difficult for them. But otherwise, the literature is pretty consistent in terms of what kind of supports might be helpful, but also what the symptoms of that really look like. Okay. Well, I hope this was interesting. I really love this talk. It's very near and dear to my heart. I am the first person ever at Memorial Sloan Kettering to talk about physician grief. So, which is crazy because it was a cancer hospital. But so the point is, it's important. I think it's important that we know about it and offer ourselves as a resource to our colleagues who are really dealing with this. People like to talk to psychiatrists. If you ever see someone upset and you just have psych on your coat, you'd be amazed at how many doctors and residents and nurses would just cry to me in the hallway. Never met them before, but they needed to cry. My coat said psychiatry. So, I think it is an important role that we can play. All right, thank you so much.
Let me say two things that might be helpful. Back in the day when there were fewer consults, amazingly, sometimes we would only have 1 or 2 or 3 a day. So we had more time to spend with patients and more time to do follow-ups. with some of my patients that were sick, particularly on the oncology floor, I would schedule a time when I was going to see them, almost as if it were an outpatient appointment. And I would go and I would sit down in the room and I would tell them this was their time, and they could use it however they wanted to use it. And occasionally, because they were sick or fatigued, occasionally they would fall asleep and they would wake up and I would still be sitting there. And that was extremely meaningful to the patients, that you were genuinely available. So that's a good thing to do. The other thing to pick up on the subject of crying. A lot of people, and maybe even doctors especially, regard people as being either strong or weak, when the fact is we all are a mix of strength and vulnerability. And when you cry and are still capable, that role models that for your patients, and they become more comfortable with the idea that the crying or being overwhelmed for a time by affect is not a sign that you're weak and vulnerable. It's it's not a sign that you have lost all strength. So, and I teach my patients that it's something I very commonly speak about, the fact that all human beings are a mix of strong and vulnerable, and that's just what it is to be human. And that's very helpful to put that into words. That was beautiful, and there's so many directions this could go. We could have a whole series of lectures and actually small group discussions about it. I would love to hear. I think it would be great to have a series of stories of my first death as a physician or medical student, because I think all of us have some kind of a story of their first death or their first few particularly difficult deaths. So I think that would be a terrific thing to put together. So thank you very much.
Thank you.
Wonderful.
Thank you, Barbara.